Hello everyone, welcome back to the series of lectures in neurology. So in continuation with our lecture series, we will be speaking about headache today. So let's begin. So before we understand the headache, types of headache, let us understand what are the pain sensitive structures in the brain. Okay, so what are the pain sensitive structures in the brain? They are scalp, dura mater, arachnoid mater, the arteries and the cranial nerves 5, 9 and 10. So the pain sensitive structures in the brain include the scalp, the dura mater, the arachnoid, the arteries and the cranial nerves 5, 9 and 10 are the pain sensitive structures in the brain. So headache can be classified as primary headache where no underlying pathology is found. There is no underlying pathology that is found in primary headache, and secondary headache where the headache occurs secondary to a pathological process. For example, in your subarachnoid hemorrhage, you have the worst headache of your life. So this is an example of secondary headache. Or if there is a trauma, Similarly, if there is a dural venous sinus thrombosis, right, you can have headache. Similarly, encephalitis. So any of the secondary pathologies which result in headache is called a secondary headache. Fine. So what are the primary headaches? We have tension type headache. TTH is a tension type headache where you have a band-like sensation over the forehead. Then the second most common primary headache is your migraine disorders, which we will be focusing on now. And we have the trigeminal autonomic cephalgias. TAC is your trigeminal autonomic cephalgias. Okay. So this is your primary versus your secondary headache. Now every time a patient presents with headache, there are certain red flag signs that you should be aware of. Okay. So what are the red flag signs that you should be aware of every time that a patient presents to you with headache? So this is given by the mnemonic SNOO. So what does it mean? Always examine for systemic signs and symptoms, like for example, presence of fever, presence of neck rigidity points towards encephalitis. So if there is history of worst headache of life, or if there is presence of anisocoria, then you can think of an aneurysmal SH. History of trauma. So these kind of systemic signs and symptoms you will have to see when you are thinking about your red flag signs for headache. Okay? Because trauma or raised intracranial pressure which presents with projectile vomiting, encephalitis, SAH, these are all secondary causes for secondary headache. Then you look for evidence of neurological deficits. You do a thorough neurological examination, look for evidence of deficits. For example, a space-occupying lesion such as a tumor can cause compression of structures, and if it causes compression of a pain-sensitive structure or it causes raised ICP, then you can have neurological deficits. Okay, then onset, you will have to think of the onset. Worst headache of my life, it is suggestive of SAH. So most often onset will also give you a clue whether this is a red flag sign. Then you will have to see the elderly patients, right? So most of the primary headache occur in younger individuals and they start early in life. So if an elderly individual is presenting to you with headache, always think of secondary underlying causes. For example, a giant cell arteritis. Giant cell arteritis is an immunological process where you can present with headaches. So the treatment for GCA is obviously different. It warrants immediate steroid treatment or there is a risk of ipsilateral eye blindness. We will be learning this in rheumatology. Then headaches which vary with position. For example, when the patient sits up, if the headache worsens on sitting up, this is an example of a low CSF pressure headache. Low CSF pressure headache. Where do you get this low CSF pressure headache? For example, your patient has undergone some surgery under spinal anesthesia, you have done a lumbar puncture for this patient and there has been a rent or a leak. So if there is a CSF leak that is going on, then the headache is more in an upright position. Alright. Then if the headache is occurring with pregnancy or postpartum, you have to be even more careful when you speak about headache. So SNOOP is your mnemonic for remembering the red flag signs for headache. Okay. Fine. So we will be discussing about one of the most common causes of headache, which is migraine. Okay, so migraine is a huge chapter in itself, and that's what we will be looking at now. So what is this migraine headache? A migraine headache is a primary headache disorder. The migraine headache is a primary headache. So there is no underlying pathological process which is happening in your migraines. Okay, so what are the diagnostic criteria and what is the definition of a migraine headache? So the migraine headache is commonly seen in younger individuals. So it starts as early as your late school years or your college days itself, and it is more common in females than in males. Okay, so this migraine headache is characterized by repeated attacks of headaches which last from 4 to 72 hours. So there are repeated attacks of headache which basically last from 4 to 72 hours with a normal physical examination. Okay, and you have at least 2 of the following features plus 1 of the following features. So what is it? It is a unilateral headache. So always remember the onset is unilateral. So the onset is unilateral, but it can then extend and it can involve bilateral areas as well. So remember, onset is unilateral. So it is usually a unilateral throbbing type of headache, more so in the temple region. And this is aggravated by movement and it is moderate to severe in intensity. Okay, this is a unilateral headache which is throbbing in nature and it is aggravated by movement and it is moderate to severe in intensity. Most often migraine headaches usually start by afternoon and they worsen in the evening. They start by afternoon and they worsen in the evening, and that is why this is also called as office headaches. Okay, this is why it is also called as office headaches. So migraine headaches are often debilitating and it prevents the person from working, and this is one of the most common causes of headache which contributes to leaves in the office because it comes in the office hours. Okay, so this is your office headache, which is your migraine headache. Plus one of the other following features, it is associated with nausea, vomiting, photophobia and phonophobia. What is the meaning of photophobia and phonophobia? Photophobia means difficulty or extra sensitivity to light. Phonophobia means high sensitivity to sounds. So a migraine headache patient, how will they present? They will have difficulty in concentrating, they will have a lot of irritability, and even a light or a sound impulse is going to irritate them, right? They will prefer taking rest in a dark room. Okay, so they prefer taking rest in a dark room. So what are migraine headaches? They are unilateral in onset, throbbing type of headache which is moderate to severe in intensity, and it is aggravated by movement, relieved by rest, characterized by nausea, vomiting, photophobia, phonophobia. And remember, these headaches are quite debilitating. Okay, so this is about what is migraine. Now let us understand the pathogenesis of your migraine headache. Okay, so the first step in the pathogenesis of your migraine headache is that there is vasodilatation. There is abnormal vasodilatation. There is abnormal vasodilatation of all the vessels which are present in the meninges. So the meningeal vessels are abnormally dilated. Now these impulses are then transmitted. They are then transmitted to the what we call as the trigemino cervical complex. Okay. So these impulses are transmitted to the trigeminal nucleus, which then transmits it to the trigemino-cervical complex. Okay, the trigemino-cervical complex then carries this information to the quintothalamic tract, to the thalamus and the hypothalamus. So the dilatation of the vessels are basically sensed as nociceptive stimuli, and hence there are nociceptive impulses which are then carried downwards in the opposite direction, which is basically responsible for the excessive pain. Okay, fine. So the trigemino-cervical complex is your first order neuron which is stimulated, and the second order neuron is the neurons which carry the quintothalamic tract to the thalamus. So the thalamus interprets these kind of stimuli as nociceptive stimuli and it releases molecules. It releases molecules like CGRP. So CGRP is calcitonin gene related peptide. So whenever the thalamus is stimulated, it releases molecules such as calcitonin gene related peptide. So this CGRP, which is calcitonin gene related peptide, is basically the molecule which is responsible for the pain and the allodynia which is seen in a migraine attack. Apart from this, there are other nuclei which are also involved, like locus coeruleus, and we have certain other neurotransmitters such as serotonin. The other neurotransmitter which is involved is your serotonin. So serotonin is the one which basically helps in pain modulation. So we can see that serotonin agonists are given in the management of migraine therapy because it helps in pain modulation and reduces the pain. Whereas we give CGRP antagonists because CGRP stimulates the pain, it increases the allodynia. Allodynia means abnormal response to normal stimuli. So there is an abnormal painful response to normal stimuli. So this is brought about by CGRP. So the excessive pain is brought about by CGRP, and hence we give CGRP antagonists in the treatment of migraine. Okay. So this is about the role of your trigeminocervical complex ventothalamic tract in your migraine pathogenesis. Okay, so basically there is a neurotransmitter disturbance and there is excessive stimulation of pain pathway. Alright, fine. Now what are the triggers? Always remember that the migraine headache will have certain triggers. So glare or excessive lights, excessive sounds, hunger, stress, hormonal changes, lack of sleep or exercise, and alcohol consumption. Lack of sleep or exercise and alcohol consumption, hunger, hormonal changes, stress, glare, lights, sounds, all of these can trigger a migraine attack. Many of the patients also have high sensitivity to different types of smells and even osmolarity changes So they have a lot of sensitivity to smell and even osmolarity changes. Osmolarity changes means if there is a slight disturbance in the total body volume, then they can have migraine. Okay. So what are the phases with which a migraine attack presents? The phases include a prodrome phase, a headache phase, and a postdrome phase. So the prodrome phase basically involves irritability. The patient will be irritable, patient will have mood changes. The patient will have mood changes. They can have excessive yawning. Right? So they have irritability, they have mood changes, they can have excessive yawning. Right? Then it goes into the headache phase. The headache phase is characterized by unilateral severe throbbing type of headache. And followed by the headache, you can have a postdrome phase where the patient is very tired and there is decreased concentration ability. Okay, so this is about your prodrome, your headache and your postdrome phase. In certain individuals, the prodrome phase can also go into another phase which is called as aura followed by your headache. So we have a prodrome followed by an aura followed by a headache. So what happens in an aura? Aura basically refers to subjective symptoms which are So an aura basically refers to subjective symptoms which are not appreciated by others. Right? So the patient will be having subjective symptoms which are not appreciated by others, and this is what we call as an aura. So what are the types of aura they can have? So they can have some auras like scotomas. Or flashes of light. Fine. So this is about the various phases of a migraine attack. So in a migraine with aura, you can have zigzag lines, you can have scotomas, which are most common. Now, this is your classical migraine. Till now what we have discussed. Now you have certain variants of migraine. What are those variants? So we have ophthalmoplegic migraine. Ophthalmoplegic migraine where with the headache you can have paralysis of your extraocular muscles. Then retinal migraine. How does a retinal migraine present? So during the aura phase you can have loss of sight. You can have loss of sight or blindness can happen along with the headache, then it is your retinal migraine. Then basilar migraine, where you have vertebrobasilar insufficiency. You can have transient dysarthria, dysphagia, dysphonia, all of these symptoms of basilar artery migraine. So it will be confused with a posterior circulation TIA. So the characteristic feature of a basilar migraine is that on evaluation you do not have any evidence of vascular disease. There is no occlusion, there is no evidence of any infarct. Even if it is a TIA, there is nothing to suggest a TIA. Only the symptoms will be similar to a TIA. So how do you diagnose this? They will give a classical history of headache along with these symptoms. Then cyclical vomiting is a form of abdominal migraine. It is a type of abdominal migraine where you get cyclically episodes of vomiting. Okay. So this is about the various variants of migraine. Then another very important part of your classification of migraine is called as your FHM, which is a familial hemiplegic migraine. So we have familial hemiplegic migraine. So this FHM or familial hemiplegic migraine basically occurs due to mutations in your ion channels. Okay, so it is classified as types 1, 2 and 3. The familial hemiplegic migraine is classified into types 1, 2 and 3. And this occurs due to mutations in your ion channels. So familial hemiplegic migraine 1 is a mutation of your CACNA calcium ion channel, which accounts for up to 50% of the familial hemiplegic migraines. 2 is a disorder of your sodium potassium ATPase, and 3 is a sodium channel defect SCN1A defect. Okay. So this is about your familial hemiplegic migraine. FHM type 2 is seen in 10% of the individuals. Okay. So this is about the various variants of migraine. Now let us understand the management of migraine. So acute management. If a patient is presenting to you with an acute attack of migraine, the cornerstone management is with analgesics like ibuprofen and naproxen. Right, so the cornerstone of management of patients with migraine is with ibuprofen and naproxen, which are your NSAIDs. Then 5-HT1B, 1D agonists, which are your triptans, can be used. So this includes your sumatriptan. Then we have your zolmitriptan. Okay, sumatriptan and zolmitriptan are examples of 5-HT1A, 1D agonists, which is your triptan. What is the contraindication to a triptan use? So the presence of a CVA, the presence of a previous history of MI, previous history of CVA, all of these are contraindications to the use of a triptan. So the clinical efficiency depends upon the Tmax and it depends upon the bioavailability. Hence, monotherapy with triptans alone has not been found to be very useful. So monotherapy with triptans alone has not been found to be very useful, and hence there is a higher rate of recurrence with these. So the management of an acute attack of migraine should be with NSAIDs and triptan, the combination of naproxen with a sumatriptan. Okay, because a monotherapy with a triptan is not very useful, and hence a combination of naproxen with sumatriptan is used in the management of an acute attack of migraine. Then, during your acute attack, the next group of drugs that can be used is your CGRP receptor antagonists, which are called as GPANs. So you remember remogepant and ubrogepant, right? So all of it sounds like R and R, so they are oral. So remember R and R, remogepant and ubrogepant are oral medications which are used in a management of acute attack of migraine, and they are CGRP receptor antagonists. Okay, then we have 5-HT1F agonists, which are ditans, which are the newer group of drugs. So they are lasmiditan. So the main important advantage is that it does not have any vascular side effects. It does not have any vascular side effects, and hence they are not contraindicated. They are not contraindicated in MI or stroke patients. They are not contraindicated in MI or stroke patients. However, they can have dizziness. The next group of drugs is your antiemetics. So when it comes to antiemetics, what are the drugs? Which is your domperidone and metoclopramide. So we have your domperidone and metoclopramide, which are your next group of drugs which can be used. Other options include opioids, which help in pain regulation, and neuromodulatory therapy, including transcranial magnetic stimulation. Transcranial magnetic stimulation is a neuromodulatory therapy which can be used in your migraine therapy. So this is about the various drugs which can be used during an acute attack of migraine. Now, following an acute attack of migraine, we should know that there are a group of drugs which can be used in migraine preventive therapy as well. So, whom are those patients whom you want to do your migraine preventive therapy? So, in those individuals who have more than 4 attacks per month, those individuals in whom you have more than 4 attacks per month, you may have to do a migraine preventive therapy, or if they have too many debilitating symptoms, unable to perform their work, then you initiate them on migraine preventive therapy. Right, so the class 1 drugs include your beta blockers like propranolol, which are your non-selective beta blockers. So they are contraindicated in patients who have reactive airway disease. Okay, and always monitor the BP before initiating these agents. Right, then you have tricyclic antidepressants like amitriptyline and anticonvulsants like topiramate. Topiramate has a high risk of formation of kidney stones. So you remember this much. So this is your class 1 drugs. So what are the side effects of beta blockers? They can cause decreased energy, tiredness, postural symptoms, and they are contraindicated in asthma. So the TCAs, which is your amitriptyline, what are the side effects? The side effects includes a lot of drowsiness. Topiramate also causes, apart from kidney stones, it can cause paresthesias, cognitive symptoms, and increased risk of glaucoma. Okay, but the class 1 drugs are your propranolol, TCA, and anticonvulsants. The second line drugs which can be used in the prevention of migraine therapy is your venlafaxine and flunarizine, which is a calcium channel blockers. The newer drugs which are used in migraine prevention is your CGRP antagonist. What we saw in the treatment is your CGRP receptor antagonist, which has oral RRR. Okay, so ubrogepant and rimogepant, which are oral drugs. Here we have CGRP antagonist monoclonal antibodies like erinumab, eptinizumab, and galcanezumab. Which are CGRP antagonists. Okay, they can be used in migraine prevention therapy. Apart from that, last but not the least, we use your onabotulinum toxin A, which can also be used. So with this, we have come to the end of our topic on migraine, right? So we have understood what is migraine, what are the triggers, and how do you manage. Okay. Now, before we close the chapter on migraine, a very, very important thing about migraine when a patient comes to you is advising your lifestyle modifications. Okay, this is something that becomes very, very important when it comes to practical clinic issues, right? So you advise your patient about lifestyle management. You talk to them about a good sleep, a regular sleep pattern. Okay, then you will have to talk to them about eating habits, eating on time, avoiding the triggers, right? So with effective lifestyle management, including a good exercise, you can control migraine to a huge extent before initiating them on all of this pharmacological treatment that we have discussed. And you also teach them about maintaining a headache diary. What is a headache diary? So you will have to teach them about maintaining a headache diary where they note down what type of headache and when did it happen, for how long it lasted, what was the trigger, and so on and so on, right? So this is about migraine. Now we move on to the last section of our chapter on headache disorders. So now we will move on to the last section of our chapter on headache disorders. So now we move on to the next most important amongst your primary headache disorders, which is your TACs or your trigeminal autonomic cephalgias. So TAC or trigeminal autonomic cephalgia is basically a disorder characterized by hyperactivity or increased abnormal electrical discharges, where along the trigeminal nerve. Which segment? The ophthalmic division. Ophthalmic division of the trigeminal nerve is going to have abnormal electrical activity and it sends out pain sensation. So it sends out pain sensation. There is severe facial pain along the V1 segment along with excessive parasympathetic activation. There is excessive parasympathetic activation. So there is excessive parasympathetic activation which basically results in tearing and conjunctival suffusion. So there can be tearing and conjunctival suffusion and hence it is commonly confused with sinusitis. So there can be tearing and conjunctival suffusion which can commonly be confused with sinusitis. Okay, so this is about your TACs. So what are the names? What are the types? So we have cluster headache, we have paroxysmal hemicrania, and we have SUNCT and SUNA. So what is the full form? So SUNCT and SUNA. So what is the full form? SUNCT stands for short lasting unilateral neuralgiform headache. Okay, it's short lasting unilateral neuralgiform headache with conjunctival tearing, Okay, then what is SUNA? SUNA basically stands for the same short lasting unilateral neuralgiform headache with cranial autonomic symptoms. A is cranial autonomic symptoms. Okay, with cranial autonomic symptoms. So this is your SUNCT and SUNA. So how is a cluster headache different from paroxysmal hemicrania, different from SUNCT and SUNA? Because your treatment options are slightly different. The more basic pathophysiological process is that all of them are trigeminal autonomic cephalgias. So first of all, cluster headache is more common in males, paroxysmal hemicrania is male and female equal, and same with SUNCT and SUNA. So cluster headache is more common in males. So what is the type of pain, right? Unlike the throbbing type of pain, they have sharp lancinating pain. So all of them or most of them have a sharp stabbing, excruciating, lancinating pain which is present along your trigeminal distribution, especially in the orbit and temporal. Right? Paroxysmal hemicrania has a hemicrania. So hemicranial headache, which is again a boring, stabbing, excruciating headache, and a burning pain severe to excruciating in your SUNCT and SUNA as well. SUNCT and SUNA predominantly periorbital region. All the others have a orbital and temporal region predominance. Okay. So the main difference is about your attack frequency and duration of attack that you have to remember. So the attack frequency of cluster headache is about 1 per day, okay, to 8 per day. But the attack frequency is higher when it comes to your paroxysmal hemicrania, which can be 1 to 20 per day. So it's definitely more than 5 per day, and SUNCT and SUNA can be up to 100 per day. So if you just take cluster headache, paroxysmal hemicrania, and SUNCT and SUNA, right? So the attack frequency increases, whereas the duration decreases. So as you can see here, the duration of an attack for a cluster headache, this is your duration. So for a cluster headache, it is around 15 minutes to 3 hours. But here in your paroxysmal hemicrania, it's only 2 to 30 minutes, whereas SUNCT and SUNA is only for a few seconds. So this is hours, minutes, seconds, right? So cluster headache has an attack of about 1 to 8 per day. This is definitely more than 5 per day. You can go up to 100 per day in a SUNCT and SUNA, And Sungd and Suna last only for few seconds. That's why it's called short-acting neurologiform headaches, right? So they last for only few seconds, whereas cluster headache lasts for hours and paroxysmal hemicrania usually lasts for few minutes. Okay, then all of them have autonomic features because this is common to all the types of trigeminal autonomic esophagias. Then migrainous features, yes, all of them do have migrainous features as well, and hence they can be confused with your common migraines. Alcohol is a trigger for cluster headache. It is not a trigger for the other two. Cutaneous triggers are present for Sungd and Suna. And alcohol is a trigger for cluster headache. Cutaneous triggers, even the smallest, slightest of touch, because of allodynia, there is exaggerated pain response to normal stimuli, right? So normal or innocuous stimuli. So cutaneous triggers are seen in Sungd and Suna. Alcohol is a trigger for cluster headache. Indomethacin is effective in what? In paroxysmal hemicrania. Very, very important point. It can be treated with indomethacin. Okay, so when a patient presents with an acute attack, what are the treatment options which are available? So the treatment options available for cluster headache is sumatriptan injection or nasal spray, zolmitriptan. You give oxygen. So you give 100% oxygen, and sumatriptan can be given for cluster headache. But the first line treatment is put them on 100% oxygen. Once they have improved from the acute attack, preventive treatment using verapamil or galcanzumab, which is your CGRP antagonist. Then topiramate lithium can be used, but verapamil is the most commonly used drug for prevention of cluster headache. Acute attack of cluster headache, give 100% oxygen. Paroxysmal hemicrania, there is no effective treatment during an acute attack, but indomethacin can be used during your next attacks, right? It helps in the prevention of paroxysmal hemicrania. Sungd or Suna are very, very painful conditions, and hence IV anesthetic like lignocaine, which is a IV anesthetic, has to be given, and prevention is using lamotrigine. L and L, prevention is lamotrigine. For treatment we give lignocaine. Okay, clear? So this is about your cluster headache versus paroxysmal hemicrania versus Sungd and Suna. So with this we have come to our end of our discussion on headache disorders. Thank you.